Hello, my name is Dr. Brad Reynolds. I am a postdoctoral fellow in my second of 2 years at Cedars-Sinai Medical Center. And today I really wanted to touch upon a topic in a way to sort of expand my interest in neuropsychology and helping to teach others about what I feel is a very valuable field in itself in understanding the human mind and human behavior, is to go through substance use. All of these things that we're going to be talking about are integral to understanding sort of the cognitive and psychiatric underpinnings of substance use, abuse, dependence. And of course, how does it sort of, where does this behavior start from a neuropathological standpoint? And how does it impact human behavior over time? And really to get a good sense of that, today with just a basic overview, sort of a neuropathological review of the systems, the substances, and the different elements that come into play when studying substance use. So I plan to use today sort of just as a brief discourse, if you will, on substance use from an anatomical standpoint, and what are the areas we're going to be focusing on as we go through the different substances themselves, starting with the most prevalent, like alcohol, and of course with the advancing legalization process, cannabis, working our way through how these different substances impact the brain, and of course, how do they kind of play themselves out, both in recurrent use, but also what are the residual effects of these substances. If you're somebody who, consumes pain medications off-label at times for years and years, will that have an impact on you at the moment? And what happens if you're able to get off those medications and wean yourself off successfully? Does your brain bounce back? Emotionally and cognitively, will you bounce back? So these are questions I think people have because all of us, I think, know somebody who has been impacted by substance use, or maybe themselves are dealing with substance use difficulties. And these are questions sort of wondering, am I damaging my body beyond what I already know at a surface level to be medically unwise for folks, of course, suffering from abuse and dependence? In terms of neurology, and I'm using that very globally, but more of just looking anatomically at the brain, the striatum is a term. They call it sometimes the ventral striatum within the literature, but it really is looking at the nucleus accumbens, the caudate nucleus, and the globus pallidus. And these structures share many bidirectional connections with the frontal lobes of the brain, the insula cortex, the amygdala, the hippocampus. These structures sort of have a foundational role in processing of reward, appetitive behavior towards things that are thought to be desirable or beneficial to us as organisms, and of course play sort of a concert supportive role to the frontal lobes in decision-making, problem-solving, and balancing the social and emotional consequences versus the rewards and behavior within specific environments. So these structures are very fundamental, and they subserve the frontal lobes, which we're going to talk about next, in a nice sort of powerful set of connections. And these areas often are studied within mice in particular due to the similarities in structure with the human brain for how they impact substance abuse, dependence, and how our behavior changes in response to recurrent dependence and abuse. So the frontal lobes, as I just mentioned, the most advanced or evolutionarily advanced are the prefrontal cortices, both the dorsolateral at the top, the medial, the ventromedial, and orbital frontal, which are used kind of overlapping within the literature. These areas oftentimes in humans aren't done with synaptic pruning until you're in your mid-20s. And these areas innately make us human in the sense that we're able to engage in higher order behaviors. We're able to analyze our thoughts, analyze our behaviors, make flexible, adaptive changes based on the environment and based on the responses that we partake in. So the dorsolateral is the most, I wanted to say northern, but superior of those, if I'm going to use anatomical directions correctly. The dorsolateral prefrontal cortex deals with working memory, attention allocation, eye motor movement, especially on the right side with the frontal eye fields being there in the frontal lobes. It also deals with problem solving, motor planning, and perhaps most importantly is sort of how does it guide motor behavior in response to the decisions that we do choose to make in concert with the other frontal structures. The medial frontal is best described by the damage that is caused by lesions to this area and the area right behind it, which is the anterior cingulate cortex, which is sort of at the genu, which means the knee of the cingulate cortex. This area, when damaged, results in abulic, amotivated, inert behavior. It's sort of an absence of behavioral pursuit, an absence or disturbance of appetitive behavior. These patients are, when they have lesions to this area, have flat affect, emotionally difficult to rouse, behaviorally are difficult to stimulate. And so obviously this is going to be a critical region in initiating behavior in response to reward processing, in response to decisions that we elect to engage in with all the frontal lobes and all those structures we just talked about in the striatum. The orbital frontal and ventromedial areas really came into light back in the study of Phineas Gage. And I'm sure for you psychology buffs you remember, but Phineas was impaled with a tamping rod that was blown through his brain. And it hit many different structures, of course, but the orbital frontal ventromedial lesions were also hit. And the orbital frontal obviously being near the orbital bone above the eye. These areas deal with sort of social, emotional behavior. And I apologize for that. Apparently, the police are coming to arrest me for talking about Phineas Gage. But all jokes aside, these areas, like what Phineas, after he suffered the damage, he was impulsive. He showed apathy for his bad behavior. Socially, he was inappropriate. He was vulgar. His personality in many ways had shifted. And so social decision-making, planning and responding socially to feedback within a specific environment is impacted by these areas. So of course, drug use is going to be integral in terms of understanding how we engage in substance-seeking behavior, and how we choose to use substances and keep using substances is going to be based on how we react to the environment. So of course, based on that, the ventromedial and orbital frontal areas are going to be of grave interest to us. The familiar neurotransmitters here, if you have any background in psychology, you're probably at least at a surface level familiar with these different neurotransmitters. Dopamine, of course, is the foundational neurotransmitter that deals with reward, addiction, and motor control. Obviously, the basal ganglia being a foundational point for dopaminergic activity, clearly going to be dealing with appetitive behavior, reward seeking, and the positive response we get from achievement of those rewards. Serotonin, on the other hand, also plays a major role in impulsivity and likewise in substance abuse and dependence because it's a neuromodulator. It's a hormone regulator. It plays much more of a sort of an offensive coordinator for the brain. It directs release, and it modulates activity of other neurotransmitters. And of course, it impacts things like sleep and appetite, both of which influence emotion, both of which, when pursued or resisted against, can result in different emotional changes. Norepinephrine, similarly, and in concert with serotonin, has to deal with it can play somewhat of a modulatory role, particularly in the release of glucose, but it's also involved in memory, attention, and behavioral activation. Now, GABA and glutamate are sort of the two children, the most prevalent children within the cerebrum, within the CNS in total. GABA being the most prevalent inhibitory neurotransmitter, and glutamate being the cousin and the more prevalent excitatory neurotransmitter. Both of these work in terms of in different ways in terms of guiding and inhibiting different behaviors in response to drug stimuli. So something to keep in mind, that it's not just dopamine. Despite it being the major point, it is absolutely not acting alone when we talk about appetitive behavior in response to substances and drug pursuit behavior, as well as continuing behavior and trying to stop behavior. So continue on today I also want to just give a snapshot on drug use prevalence. So based on data collected earlier on in the 2000s, we looked at just use. So this doesn't reflect abuse or dependence. We're saying this is subclinical at most in terms of substance consumption. Alcohol use, I mean, again, if you're just flipping a coin, chances are at least 50% of the time someone you meet is going to at least have consumed some amount of alcohol in the last month. In lifetime, more than 4 out of 5 Americans have consumed alcohol, which is pretty remarkable and shows you that as a society and in terms of cultural expectations, alcohol is very interwoven into who we are as Americans. It's a social norm and expectation. I don't know about you guys, but for me, when you hear of somebody who has not drank or has outright kind of resisted any substance use in their entire life, it's more shocking than for somebody who does a lot of different substances. And that just speaks to the fact that culturally, substance use is ingrained in who we are. We know it to be a very palpable reward, and we also know it to be a social lubricant. For many of these substances, it allows us to be social human beings, alcohol being one of the most popular, if not the most popular, social lubricant, so to speak. Marijuana, and this is going to be an underestimate for marijuana, has certainly gone up in prevalence with the change in legalization. Back then, I can't even remember if Colorado, which has been one of the more progressive in terms of legalizing marijuana and making it more available and accessible to the general population, with all of that changing, especially in my home state right now of California, every corner you go to, you can go into and secure a cannabis product. So certainly past month use has probably grown vastly from this estimate, which again, it was published in 2015, but the data is usually collected and analyzed for years before the study comes out. It's not automatic. And then certainly prescription misuse is one of those things where I think people tend to underreport. Just from experience of being on the acute rehab side, and again, I know this is a clinical population with a lot of comorbid medical issues, but things like opioid abuse or off-label use of prescription medication is pretty prevalent. I would say it's in at least 1 out of 10 patients I encounter is folks that are deviating from physician recommendations and misusing prescription drugs. So certainly you want to know, okay, well, what percentage of folks meet criteria for substance use disorder? And per the DSM, this involves a significant amount of use on at least 2 occasions, and I'm using alcohol as an example for that, associated with 2+ different symptoms. They're usually emotional, behavioral, and cognitive symptoms. And again, the DSM-5 being yet another iteration of the American Psychiatric Association's attempt to sort of lay out the profile or syndrome of substance use, it gives a lot of good examples. So things like craving, withdrawal, increasing tolerance, failure to maintain abstinence with multiple attempts to do so but failing to do so, or continued use in either hazardous situations, maybe in situations in which psychological well-being is deteriorating, but the drive to use is overriding that. These are different sequelae that get counted into that number, and depending on the amount, if it's greater than 2, you'll meet, or if it's 2+, you will meet criteria. But there's different number amounts of those symptoms to meet criteria for a mild, moderate, and severe substance use disorder. So again, say what you will about the limitations of the criteria. Certainly, amount of symptoms doesn't always translate to clinical severity, but that's the way it's chopped up in the DSM-5. So knowing that, at least mild substance use disorder, almost 30% of folks would meet at some point in their lives meet criteria for alcohol use disorder. And any drug use disorder being 10%, up to 10%. Cannabis is certainly going to be one that's probably going to be advancing based on the criteria. But you can see, even for drugs that we think are less common, like abuse of heroin, for example, it's still pretty prevalent, especially in lower socioeconomic rural communities. You might see something like heroin abuse, methamphetamine abuse to be much more prevalent, whereas cocaine being much more of a higher socioeconomic cornerstone of substance use, likely to be more prevalent in like big cities in the higher class groups, particularly among white males. So depending on context, these prevalence numbers are going to change, but at least globally, just looking at a large population of Americans, this is where we're at. And of course, I want to highlight too, just for the cultural relevant point, is that for like Native Americans, for example, these numbers are skyrocketing, and they have always historically been higher, the amount of substance use and abuse within those communities, and it's an understudied population. So you think these numbers look bad now, put it in an underserved, historically traumatized group with very limited mental health resources, that being Native Americans. And I got exposure to that in my time in Oklahoma when I was at the University of Tulsa. A lot of folks meet criteria there with Native American background. It's very unfortunate, and something that really, as Americans in our history, have sort of started in terms of what we did to that population, and how we still need to kind of figure out a way to treat and triage their mental health difficulties appropriately. The one I will start with today is just alcohol use. Really briefly, it's largely processed in the small intestine, but it does get somewhat absorbed in the stomach. And the interesting fact about alcohol, and maybe you've experienced this yourselves in terms of just light social drinking, I hope, is that low dose, meaning like 1 or 2 drinks. And a drink can be a 4-ounce glass of wine, a shot of liquor, a 12-ounce light to medium draft beer. This low of an amount actually increases impulsivity. It actually acts as a stimulant. Now, the reason why it says processing going down is processing tends to become inaccurate. So cognitively, your sort of ability to judge your behavior and control your behavior diminishes, motorically, sensory-wise, and cognitively, but you're stimulated in a way that makes you sort of function socially more freely. And that's where the social lubricant point I was making earlier comes in, especially at the low dose. Now, at moderate doses, we tend to have 3 to 6 drinks is how they categorize that, or at least how research has categorized this. And again, it differs for individuals. You know, if you have low alcohol tolerance, 3 can be quite a bit. For somebody with heightened alcohol tolerance in the midst of chronic drinking, 3 to 6 is nothing based on how their system has adjusted or acclimated to recurrent use. But that being said, 3 to 6 is where you start to see more profound cognitive difficulties. This is where, particularly encoding, which as you can see at the bottom there with blackouts, is actually what is thought to cause the actual the blackout syndrome that we all have heard of, hopefully never experienced. The idea is that your brain is able to register information, meaning you're online in the moment, but the actual encoding and consolidation of memory, that process is rendered basically useless when you're very intoxicated. So you're online, you're creating the initial sort of imprint to make memory, but to actually encode and log that in, it's not getting there. So the file is started to be placed into your filing cabinet, like we have a folder there for the night, but there's no real details or paperwork getting into that file. And when you try to retrieve it in the morning, there might just be a file there, but it's completely empty. So nothing really got filed away. And then, of course, at the high dose level, greater than 6 or 7 drinks, that's where we start to see profound anterograde memory loss. And for folks that are repeatedly drinking this much, that's where we see the Korsakoff syndrome, familiar to some folks, the Wernicke-Korsakoffs, where anterograde amnesia is sort of a hallmark of that. And that's brought on, we don't have time to talk about it, but it's the primary mechanism is thought to be brought on by thiamine deficiency. And so thiamine supplementation is thought to be useful to breaking that syndrome and helping restore memory function. Now, the mechanisms of it, it activates the dopaminergic pathways in our familiar friend, the nucleus accumbens. And the ventral tegmental area is also is adjacent and I believe is inferior to the nucleus accumbens. And the HPA axis, which this is the hypothalamus pituitary adrenal axis. And this has to do with activation of stress response. It is involved in hormone secretion. And the idea is that when you throw this out of whack, you're obviously going to be causing different autonomic changes within the body. And what I mean by autonomic is things like pulse, appetite, sweat secretion, respiration. These are things that, and breathing rate, temperature. These are all things that are regulated by that axis in many different ways. And so when dopamine is acting in that particular axis, that's why you get a lot of bizarre sensory, autonomic changes when you're drunk and also when you're recovering from it, because you're messing with the pathways in this system guided by the dopaminergic influx. Experience of reward, of course, comes from dopamine activation. We've already talked about that. The long-term consequences, most of us are familiar with cirrhosis, which is sort of terrible damage to the liver due to excessive alcohol consumption. But alcohol is also, due to its very strong rewarding effects, results in a strong dependence and tolerance. And actually what happens is, and part of the reason why you need to drink more to get the same rewarding effect, is that in response, our body actually reduces dopaminergic receptor availability. And so because of that, it takes more dopamine and more drinking by product of that to cause the same experience of reward. So our body as a protective measure is like, no. Like, we've got too much dopamine in there. We need to get these receptors in. We can recycle those, bring them back into the cells. We don't need any more dopamine. So to match the same effects, we keep drinking. And what we have shown too is that frontal and subcortical structures can change either through atrophy, sort of metabolic changes within those regions, cellular damage. Your brain is not going to escape the effects of alcohol acutely, and especially with recurrent. So what I've tried to do here, and it's not really well done, and mainly because a lot of this damage is not necessarily on the surface level, but more towards interior regions of the brain, and all you can see is that surface neocortex. But that being said, what you do see is global volume reductions and loss of neuronal density, particularly in the frontal areas, but also in those bidirectional areas of correspondence with the frontal lobe, that being the hippocampus, the cingulate cortex, the anterior cingulate being part of that, and the thalamus, which, as we know, is sort of that major relay station for the brain, transmitting different sensory impulses and different features of processing to different areas of the brain, both cortically and subcortically. And so when the thalamus is damaged, you can cause a whole host of cognitive, psychiatric, motor sensory changes. So it's not a good thing that this is also vulnerable. And white and gray matter, white being typically the myelinated axons of neurons within the neocortex, and the gray matter largely being the cell bodies of the different neurons in our brain. Those are also impacted both in the frontal and limbic systems, but also the cerebellum, which has a lot to do with motor coordination. And sort of, for example, is when we reach out to grab something like a cup on the table next to us, we use the cerebellum to sort of gauge how far we need to extend our arm to pick up the cup. And similarly, when we're trying to throw a baseball at a target, at a glove that somebody's holding out, the cerebellum plays a fundamental role in how do we torque our arm, contort it appropriately, and release the ball with enough force to get it to that target. So there's a lot of systems involved there, but the cerebellum is paramount in that system, with the basal ganglia, brainstem structures, and of course the frontal lobes having a lot to deal with that. And these changes are absolutely most pronounced in older alcohol abusers. Alcohol abuse can carry some pretty significant effects for folks that are suffering from alcohol abuse at an advanced age. Simply can't bounce back the way it used to, right? Metabolic changes, it takes slower to clear things out. Tissue and neural plasticity is reduced. So what do we know? Well, if we look at different domains, the most common effects tend to be executive function, memory, and motor functioning. And for executive functioning, it's a term that's thrown around. It's kind of a buzzword right now in psychology, and especially like in the industrial organizational psychology literature, it's sort of a feature of somebody who's an excellent leader. It's somebody who is dynamic, adaptive, malleable, can think on the fly, has appropriate balance of risk reward, is able to reflect on and self-monitor their behavior. Deficits are common due to the impact on frontal structures in alcohol use. And I'm going to start with current chronic users. And the same thing for memory. It's typically an anterograde amnesia, and it's most pronounced when we get Wernicke's encephalopathy, which, like we talked about, the Wernicke's-Korsakoff's syndrome can actually be prevented with timely medical stabilization and thiamine administration. So Wernicke's encephalopathy is not a great one to have in terms of it's caused by recurrent and poisonous levels of alcohol consumption. And motor imbalance, in particularly gait, the deficits are common. And when we look at residual effects, the work by Fama and Sullivan they're both fantastic neuropsychologists, neuropathologists that work at the University of Stanford. They've done fantastic work looking at how motor deficits, even subtle things like balance and gait, they measure things like walking, pacing, how do we keep ourselves upright, the steadiness of gait, the flow of transition in terms of movement. They've shown that there can be mild deficits for years even after abstinence. And so what it shows you again is that cerebellum and those subcortical structures in the basal ganglia and of course impact on the frontal lobe lead to persistent motor deficits. So on tasks where we have patients copy certain figures or shapes or maybe integrate different shapes to construct something novel, they're going to have many more pronounced difficulties. This is one of the things that may persist even with prolonged abstinence. Memory can also be something that persists, though the brain does show decent comeback in terms of recovery if you're able to get medical stabilization and remain abstinent. In executive function, the results are variable, and that's usually due for a lot of these different studies due to the fact that executive function is measured differently depending on what constructs you look at across studies. It's hard to get a robust effect size or a magnitude of effect of alcohol if what you're studying in terms of executive function, quote unquote, looks different across. And emotional processing, I should say, is impacted sometimes, especially facial emotion recognition. We have certain measures, for example, that look at, can you gauge based on a person's facial expression what emotion they're expressing? Or based on a set of information, can you kind of gauge affect for this individual? That can be impacted due to recurrent alcohol use and is thought to be associated, again, to the frontal and limbic damage associated with alcohol use, but it's not entirely consistent. So what happens if we remain abstinent? Well, what they have shown, at least a lot of these being in mouse models, because again, we like to study creatures that we can manipulate and control intake, and because alcohol use is often comorbid with things like tobacco, marijuana, other substances. Alcohol use, if you do maintain abstinence, there is signs of remyelination of those white matter changes and cellular restoration in the limbic, basal ganglia, and cerebellar structures. The frontal limbic systems in particular may benefit from sustained abstinence. Visual attention and working memory, and we talk a lot about visual motor integration, right? So, for example, recreating a complex figure and being able to accurately position different elements within that. There's been some signs of improvement if you can maintain abstinence for weeks to months. The other things that we are still trying to look at are genetic modifiers and personality factors, things like antisocial personality. It's been shown that there is somewhat of a biological correspondence to that, and when comorbid or concurrent with alcohol use can lead to its own host of pathological changes. What we're seeing is there are some subtle differences in brain structures for those that meet criteria for antisocial personality disorder. So if you have that and alcohol use, even if you treat the alcohol use, recovery and neuropathologically what it looks like may still have yet to be determined. And the complications, of course, are nutrition. Oftentimes people do not treat their bodies well. They do not exercise. They do not consume appropriate foods when they're drinking. And the residual deficits, of course, in motor imbalance that we've talked about. And Korsakoff syndrome, I want to clarify too, is if there's not a timely management of the Wernicke's encephalopathy, and encephalopathy is sort of just a fancy way for sort of brain inflammation, brain disturbance in cognition due to the alcohol use. If Wernicke's is not treated appropriately, it can develop into a Wernicke's-Korsakoff syndrome, at which point then it's going to take time for medical stabilization and resolution of the amnesia in particular, for learning new things, remembering new things. And that can take time and lead to residual deficits in itself. So again, this is the sort of first of what we're going to be covering. The next one we're going to be doing is cannabis. And again, I thank you all if you've decided to come by and check out my video. But the other thing is too, is if you've been following Neuropsych Facts on Instagram, I just want to say thank you. I started it a couple years ago. I know I don't post every week. Sometimes I go multiple weeks without a post, but I've continued to get great support from those that have stuck with me. I'm very grateful. I know it sounds stupid for even just 2,000 people following me. You know what I mean? I know people have a lot of different options for where they read things and what they check stuff out, but this is literally just a passion project for me. I love what I do. Again, I get to do a nice blend of cognitive evaluation, treatment. I get to do some psychotherapy. I also get to participate in some awesome research. I love what I do, and I think it's something that the community should be educated on because, again, understanding how our brains work and how that correspondence between brain and behavior works is really the fundamental discourse for a neuropsychologist, and I love it. So thank you again for your time, and next week, or at least in a couple days, I will get up the cannabis and marijuana discussion, and we'll go through that as well, and it'll probably be a little bit briefer than the overview today. The other thing too, just to make sure I disclose, is I have no financial interests or conflicts of interest with this. Even though I'm at Cedars-Sinai Medical Center and I've presented this presentation there, I want to make sure in terms of just to clarify for myself is that they did not approve the discussion today. They are not involved directly with this. So any issues that do come across with this video, just make sure you let me know. It does fall on me. So again, my name is Brad Reynolds. Thank you for tuning in, and I look forward to talking soon. Take care, everybody. Stay safe.